Good morning, everyone. Thank you for inviting us along here today to talk about the Topol review, preparing the healthcare workforce to deliver the digital future. Doesn't that sound exciting? Yes. So, as you said, my name's Andy Gill. I'm the Deputy Head of Strategy for HEE, with a focus on the future development of the workforce. But in this context particularly, I was the Programme Manager for the Topol Genomics Expert Advisory Panel, which was an interesting challenge and one I might be able to talk to you about after Perda, or after a few beers, whatever. So I'm going to talk you through the genesis of the report itself and the findings thereof, and my colleague Henrietta will talk to you about the exciting bits of implementation thereafter. So how did it start? Well, it was commissioned by the then Secretary of State for Health, Jeremy Hunt, in December 2017 and formally launched in January 2018. And it was led by Dr. Eric Topol, who some of you may know or have heard of if you follow TED Talks and talks about technology and innovation on YouTube. You can find all sorts of talks that he's led. He's a renowned cardiologist and chair of innovative medicine and professor of molecular medicine at Scripps Research Institute in San Diego, California. And he's author of a number of books as well, which, again, if you have an opportunity to, well worth having a look at and reading through. Interesting titles, including the Creative Destruction of Medicine, a fantastic one called The Patient Will See You Now, which is a really great read and worth having a look at. And most recently published a book called Deep Medicine, which is a focus on how artificial intelligence can empower doctors and revolutionise healthcare systems across the world. So, what was the brief? Well, there were three main questions that were set to Dr. Topol and his team. These are, so how are technological developments likely to change the role and functions of clinical staff in all professions over the next 2 decades? And then, certainly from a Health Education England perspective, what are the implications of those changes for the skills required, and what does this mean for the selection, curricula, education, training and development of current and future NHS staff? And Dr. Topol at the start of the review set out 3 main principles. He wanted and insisted, in fact, upon that patients must be included as partners and informed about health technologies. And indeed, throughout the review, service users, patients and carer representatives were involved in panels and subgroups, bringing forward their expertise and their input into the discussions. That innovation needs to be built on evidence, that the healthcare workforce needs to be supported to develop expertise and guidance to evaluate new technologies on the basis of real-world evidence of clinical efficacy and cost effectiveness. And that's a real challenge because it's not always there. And there's a real time lag sometimes for some of that evidence, but it's about how we can creatively develop, disseminate and share that information. And this third one, which is a real important, and Dr. Topol kept stressing it, this isn't about a relentless drive towards efficiency. It's not about a relentless drive towards reducing the amount of clinical staff. This is about getting back, in his words, to how healthcare used to be. It's about making sure that there is time for clinicians to have, to interact with patients, doing what they do best, which is caring, and using the technology to do the stuff that technology does best. So that those clinical staff have more time to care. So, based on those questions and those principles, the review was set up, and it was an important part of that was what are the ethical considerations, because it's not just about technology, it's about how it's used and what those implications might be, and across all, things like patient safety, governance, respect for dignity, all of those things, that technology can have a real impact for good or bad. So ethicists were included in all the Topol review panels as well. So to make sure that the ethical considerations were right there alongside the considerations about the exciting technology. So there were four main areas or themes that were covered within the panels. The first was around genomics, the second around artificial intelligence and robotics, the third around digital medicine, and in this instance, digital medicine was defined broadly as including a range of technologies, including telemedicine, smartphone apps, wearable devices, and some of the software used in clinical settings, things like e-prescribing, etc., point-of-care tests, and extended reality technologies. And the fourth one, which was, I think, really important, was included as well, was around organisational development and ensuring that we knew how all these different other elements would impact on the system more broadly and the NHS as a whole. And so in order to take these forward, we gathered the various panels together. The membership included clinical experts, those right at the top of their field, clinical rock stars, some of them were described as, people who are seen as being right at the forefront of research and development in these areas. Educationalists were there as well, people involved in developing and working with our clinicians, developing the next future set of clinicians, but also those with working with clinicians in practice at the moment. We had health economists involved as well, looking at the economic aspects, and as I said, patients, service users and carers involved across all of the panels. And the OD working group had a particular focus on cross-cutting themes and system change. And I think it's important to say, and those who were involved working with Eric, he came across a couple of times, but I think he was absolutely blown away by the NHS in general. I think he was absolutely astounded about how patient-centric the NHS was compared to some of the systems that he's worked in the past, particularly in the States itself, and the principle of universal healthcare, which we take for granted, which is not the case everywhere. And I think he saw the NHS as a real opportunity to bring all of this technology together, but actually to use it to do something really quite significant to improve patient care. We had to moderate some of his thinking about how easy some of that might be, and actually, with some of the great things about the NHS come some of the complications and the difficulties, but nonetheless, those are things that we can build on and develop. So, how did we do it? So the review sought out expert opinion from a broad range of stakeholders. Eric pulled together, as I say, a group of experts from clinical services, from education, from across the system, like I say, including patients and carers. And these panels considered evidence from a desk review of available literature. There were lots of one-to-one interviews with experts, but also people on the ground, people actually out there delivering services. So it wasn't all about pie-in-the-sky professors. It was people on the ground who are actually delivering these services. What does it mean for them? How are they able to deliver? And actually, what are the barriers standing in the way? How can we overcome those? And we visited various sites where some of these technologies are being developed and put into practice. And we held 7 roundtable events, 2 of which were around mental health, which I'll come on to in a minute. And these again included patients and patient advocacy organisation, professional groups, industry, education, regulators as well, because that's a key part of this, is how we regulate. The future will need to be different in a world where technology is supporting us in new and innovative ways. So, I mentioned earlier the mental health events. There's a document which you can see online, which is called The Digital Future of Mental Health Care and Its Workforce. And this was a brief report. It's so brief, it's 40-odd pages long, but was pulling together the evidence, both taken from those events, from visits and so on, but also from desktop review of literature around, specifically around the mental health impact of technology. And it was compiled by Dr. Tom Foley and Dr. James Woolard. And it explores the questions of technology, but as I say, with a specific mental health focus. And the findings were based on those interviews and focus groups. And hopefully that will be an interesting thing if you want to look at. If you just type Topol and mental health into Google, you'll find those on the HEE website, and there is a specific Topol website as well. I did mean to hold up as well at the start. Here's the Topol review itself, which you can download as a PDF, but I think there's still some hardback copies around somewhere, so you can order one of those via the HEE website as well. So, just talking about the overall findings then. So as part of this work, there was a kind of there was a debate and a discussion about what the most important, in inverted commas, technologies would be going forward over the next 10 to 15 years, some of which are already in place and some of which will develop over time. And this is an arrow heat map. I don't know if there's a pointer on this, there probably is, but anyway, you can see at the top, number 1, they're not necessarily ranked in order of importance, but more in terms of actually the impact over time and when they might start. Telemedicine's been around; it's been around for a while, but it's not necessarily there everywhere, and certainly not implemented to the level to which it could be. Smartphone apps, again, we'll talk about those in a couple of seconds. Right through to genomics, reading the genome, which there's more and more happening around. But actually thinking about writing the genome as well. And as we go into the future, and some of this is already happening. You'll be aware of the CRISPR and some of the other genomic writing technologies that are out there that are starting to have a real impact, very small areas, but really significant changes to treating diseases that previously have not been able to be treated in any way, shape or form. And the colour coding on the heat map is basically the darker the line, or the darker the arrow, the more impact it's having over time. So, over from 2020 through to 2040. And of course, this is a judgment call. And anyone sitting in this room can say, well, I'm not sure about that. That could be. This is a process of consensus to get to this point. It's not a prediction necessarily, but it is a kind of, if this happens, and this is what the consensus is, then actually what's the impact thereon? So, I said I'd give you a couple of use examples. Here's a couple of examples again. They're in this report. They're cited in here. If you want more information, download the report. At the back, there's a link to all the evidence that's used to bring these together. And you may well be involved or aware of some of these. So it's just a few examples. There's so many examples in here in the report of different technologies. These couple are specifically for mental health. This is around using smartphone apps to deliver cognitive behavioural therapy for insomnia. There are other examples for other conditions as well. And this is an area where, insomnia is a big issue. It has an impact on physical and mental conditions. And the first line treatment is quite intensive, and actually it's very difficult to deliver that to a population at large. So potentially technology can help us to do that, to support patients who will respond through the technology, and actually again free up time for the clinician to deal with or to support those patients who need more of a one-to-one care or who don't respond through the technology route. It's about freeing up the time so clinicians can direct their time to those patients and service users who most need it. Another example here is supporting, it's a mental health triage bot. It's supporting speech recognition, natural language processing. So people with acute clinical concerns over their mental health often find it difficult to access services. So this is a natural language processing enabled mental health triage bot, which analyses text and voice inputs for emotion and suicidal ideation, and is built into a GP IAPT pathway. And again, it's about freeing up time so that clinicians can, so that patients don't have to travel to appointments. They can get this information, and then clinicians can access those patients that they need to, or patients can access them when they need to do that. Now, again, just another example of the sorts of things that are in development and actually being applied in some areas, and for which the evidence is being developed. I'll move on now to another aspect of the report then is thinking about, so some of those things are already happening, but what are the things that might come along in the future? And again, lots of examples here. I'm just going to pick one from the area I was particularly involved in, which was around genomics and the polygenic risk scores and the opportunities for sequencing markers across the genome and developing specific genetic tests for specific genetic variants associated with chronic conditions and disease, and allowing a real opportunity for more patient-specific data on which diagnosis and treatment choices can be made. So by sequencing those markers, we can identify specific genetic variants associated with conditions. When that's used in existence with existing demographic and lifestyle scoring, going back to Pete's diagram before about all the different determinants that are there, genetics is just one part of that, obviously, but it is an important part that you can put together with other elements. And the particular example involved here is around coronary heart disease in the general population, particular feature of the risk scores, so that we can actually apply them much earlier than you would normally detect issues, and actually that allows then you to develop preventative measures which are much more effective. And one of the reflections from the review was that with wider use of genome sequencing, we're likely to be able to predict which antibiotics are suitable for particular infections. Prescribing decisions will be made according to the patient's or the pathogen's genetic sequencing. And that's the other thing. We can sequence not only people's DNA, but actually the DNA of the pathogens, so that we can understand them more clearly and how to combat them, so that you become able to direct and personalise treatments, not just to the patient, but to the specific pathogen involved with them. So all sorts of exciting developments and potentials there for the technology, which is all great, excellent. But it's not going to happen by itself, or at least it's not going to happen as effectively as it could. We're not going to get the real gains as much as we could if we actually do something proactive to make it happen in the way we want it to happen. So the Topol Review Board came up with a set of recommendations, 46 of them, So we'll go through them all word by word. No, we won't. But these 46 recommendations were presented to the Secretary of State, who had changed in the meantime, which is always fun. But I think were well received and certainly were listened to. And Henrietta will talk to you about some of the actions that are arising in terms of implementing some of these. I'm going to talk. I'm going to put them all up, but I'm not going to talk through them all. You'll be very glad to hear. I'm just going to pick out a few and just. And just reflect just quickly on some of them. So, as I say, in each section we considered the citizen and the patient, what it meant for healthcare professionals, and what it actually meant for the health system, and what the implications were, and what needed to happen. So for instance, around citizen and patient overall. It's seen as really important to be engaging with and educating the public about genomics and digital health care technologies. Actually, we need to work with patients and carers, so we all move forward together. We can't do this individually as a healthcare system imposing. It has to be working together. Again, looking at so now thinking. So that was a general. A general recommendation, looking at some of the individual areas, looking at genomics. You'll see G2 there, healthcare professionals should receive more core training in genomic literacy. This is something that potentially is for everyone to have some kind of understanding, both those who are coming through the system where it's been introduced in the curricula, but actually those already working in the system, and where it's appropriate, where it will impact and make improvements. And it isn't just about educating people once, because this technology, like all others, is developing. It's about lifelong training, and how do we make that available to support people. Thinking about the health system, G7 talks about a framework for genomic leadership developed across clinical specialties and primary care, giving people the opportunity to become leaders and experts in this area to support their colleagues across the piece. Moving on to digital medicine, again just picking one out here, DM3. It's about investing in the existing workforce where appropriate to develop specialist digital skills. So it's about helping and supporting staff again. And again, we'll talk about some of the implementation around this later on. There's a joint one across digital medicine, AI and robotics, which is about increasing the number of clinicians, scientists, technologists and knowledge specialist posts with dedicated accredited time. And that's, again, important. This shouldn't be about people having to do things in their own spare time and developing their issue. This should be a core part of what healthcare professionals are allowed to do as part of their accredited time to build their knowledge and understanding. And then they are the ones, alongside patients, who can work with academia to make sure that what's developed is right and supportive, rather than having to adapt or adopt something that's kind of pushed onto them. So it's about developing that clinical expertise. I know time's moving on, so I'll just move through this quite quickly. Again, you'll see here AIR, which stands for Artificial Intelligence and Robotics 2, talks about developing educational resources. So this is about making sure we've got the support and the resources for people available. Again, looking at all the organisational development elements, OD3, it's about healthcare professionals being given access to those resources. No good just having them somewhere on the shelf that we can't get to. It's about giving them access to those resources, but also ensuring that patients, citizens and staff are involved in the co-design and development of these projects, as you'll see in OD1. And again, just talking about the health system, making sure that we have strength systems, OD6, to disseminate lessons from early adoption and share examples. There's no shortage of brilliant ideas out there. There's no shortage of people doing some fantastic work. What we're not very good at as an NHS is sharing that and adopting what others have developed as well. The old not invented here syndrome is something that we need to fight against. We need to work for the best benefit of patients and service users, that we are working to the best possible practice and sharing that. And it's not easy. So we've got to find ways of making it easier for people to do that. And then finally on this bit, it's about developing frameworks to implement technological solutions and ensuring staff are trained. So it's about making sure that we bring patients with us, that we help them, that we're making sure that what we're developing from a technology point of view fits with the needs of patients and clinicians, that it isn't imposed on them, that they are involved in developing it, and that they're given time and support and resources to do that. And that's not easy, because it costs in terms of developing those resources. But in terms of, if we're going to do this properly, and if we're serious about doing this properly, then those are the sorts of things we've got to invest in. And education and training is a key part of that. So I'm just going to finish my section now with a short video by Dr. Topol himself, who can say these things a lot better than I can, and then I'll hand over to Henrietta.
No one's ever done something like this. That is, taking this new set of tools that are unquestionably having a dramatic effect on healthcare's future, and to bring all the disciplines together, all the experts, and start to plan how to use these effectively. And what can we do to really benefit patients with all these newfound capabilities? The fact that you can get a warning on your wrist through your watch that your heart rhythm isn't right, or you could get your potassium in your blood through your watch. These are some things that we wouldn't have anticipated. So the fact that you can get your genome sequence, that you can get your gut microbiome sequence, there's so many ways to understand each human being like never before. What it means is we can get remarkably more productive, that we don't do mass screenings, but we know who should be watched for whatever particular condition, that in the future we could prevent things like asthma attacks and seizures and heart attacks and strokes, and far better management of things like diabetes and high blood pressure. So there's all sorts of opportunities of improving our workflow and patient management. Reading scans, slides, looking at skin lesions. These are all patterns that are better for machines to process at high throughput accurately, and then have human clinical oversight. And that's where this is landing. This is a combination of doing the things best that machines do, but also that clinicians can do. There isn't any question that over time, and we're talking not just immediately, but in the 5 to 10 year time frame, we're going to see some immense productivity improvements. So for example, if somebody was instead of going into a regular hospital, they could go home and be on sensors and be continuously monitored with artificial intelligent algorithms. That's just one example of how we're going to see changes. And when that happens, think of all the different people that are affected. For example, we're going to need more data scientists, of which there are relatively few, and we'll have the types of specialties which are going to be very much supported through machine learning and AI. We may have less. And if we ever get the remote monitoring together, we may have less hospital personnel. So we're going to see dynamic changes across the board over the years ahead. But there will be new areas that will grow, just as there are areas that will see some reductions. So this is something that's bigger than the NHS. It really will be transformative. That eventually, just a matter of time, that the patient will be truly the center. And clinicians will be rescued from the despair of not being able to care for patients well, because they're so burdened with so much keyboards and administrative and all these other things that divert them from what they really want to do, why they went into healthcare and medicine in the first place. And then we obviously want to see the productivity in these health systems. So each of these areas will eventually be revolutionized over time. Maybe it'll take 10 years, 15 years, 20 years, and we'll look back now in 2018 as this thing rolled out is that we were able to really nail it of what is the biggest advantage of bringing all these tools together.
Thanks, Andy. That was good introduction to the what next. I'm sure you're all sitting down thinking, how does this actually translate? And Pete did say earlier on that when you get all these policy documents or reviews coming out, you think, what does this actually mean for me? So in the next few minutes, I know only got a few minutes, I'm going to whisk through this, but what I'm going to try and do is to explain or to talk about the so what. So what does this actually mean for us? It's all about education and training. I mean, coming from health education in England, I cannot talk about anything else apart from education and training. And it's really about the future workforce as much as it is about the current workforce. So we do have a workforce that would be still working in the next 20 years. We do know that. Significant amount of us will still be clinicians in 20 years' time. But equally, with all the emerging technologies, how do we begin to educate and train our future workforce? Now, we need to make it exciting. So the NHS will compete with industry. Looking at the technologies that are coming up, I mean, some of the workforce that we do need, data scientists, they are not here yet. But how do we make the NHS an exciting place for people to want to work in? Now, these young people want different kind of work. So unlike previously where somebody has a job for life or wants to follow a particular career pathway, we now have something called portfolio careers. So it's about how do we say to these young people that actually there are opportunities for you to work in the way that you wish to work using technology. But also, what skills do they need? So it's not about waiting for people to arrive and to say, this is what you need to be able to work effectively within the NHS. It's what do you need to get there? This is technology. Yep, let's see. What am I doing here that's not working? Okay. So when the Topol was completed, unlike any other review, this was actually one that had been communicated in various policy documents, and the NHS Long Term Plan was one of them. As a result of that, a group was put together, and it was called the Technical Skills Enablement. Now, the importance of technology has been picked up by everybody. So at this point, this group came from various sources, so from various NHS organizations, very senior leaders, clinicians, and this technical skills enablement was chaired by the new chair of Health Education in England, Sir David Behan. Now, this work was looking at what do we need to start implementing within 1920 to make sure that this is not lost. So there was a momentum when the Topol review was completed, but it's very much how do we carry on with this momentum without losing it? The group looked at it from three lenses. Like everything else, you do need bums on the seat. For you to be able to even begin to talk about what skills people need to do their work, you actually need the people to be there. So it's about capacity. How do we plan for the future workforce? How do we recruit them? But more importantly, how do we retain them? Because technology has a way of either getting people running away or bringing people round the table. And certainly for the current workforce, a lot of people, especially people who are almost at the end of their careers, are thinking, this is not what I signed up for, so I'm out of the door. So there is very much something about how do we retain the workforce that we have. There's also something about the culture. So whilst you've got people who are very enthusiastic and want to take all of this forward, they need a culture that fosters innovation, a culture that allows them to be able to use their skills without feeling that actually if I do this, then there are repercussions that's not always positive. It's also about capability. So what skills do people actually need to have? So it's as much as having the capacity, having the right environment, but people need the skills too. So 3 areas really that we focused on. So we talk about leadership, and I am a strong advocate for leadership at all levels, because I always believe that if we talk about leadership being up there, it means that people do not think of themselves as leaders or people that are able to implement or effect changes. So I see leadership at all levels as a way of actually implementing change. But for this piece of work, the evidence almost tells us that for you to implement any technological change in any organization, you need your board signing up to it. The board has to understand the implications of investing in their workforce, in the culture, to actually implement the technological changes. So for this work, when we talk about leaders, there's a lot of focus on boards, and I'll talk a bit more about that. Again, it's how do we get clinicians? So it's almost a movement of change. It's not so much about the technology, but it's about change. So how do we get a movement of clinicians who are wanting to use technology alongside their clinical skills and not feeling that it has to be one or the other? The third bit, which I've already mentioned, is 95% of all jobs would actually require some digital components. So there was a study by McKinsey last year, and whilst people get worried that their jobs are going to be replaced by robots and algorithms and the rest, McKinsey's work does tell us very clearly that that's not the case, because healthcare is one of the 5 industries that's actually going to need technological skills the most and will need clinicians and practitioners to use it. So we're not going anywhere. This definitely means a challenge for us. What does this challenge look like? 1.4 million staff in the NHS. There are going to be new professional roles as a result of all these emerging technologies. Learning is an interesting one, because more often than not, people are sent on courses. You do go for these training programs, and then you're asked, why are you here? And sometimes the response is, I've been sent to be here. So people go into this learning and they come back and really haven't learned much because they've been sent there. So there is a question of whether people engage more when learning is personalized for them. It's getting learners' profiles. So we know people learn differently. So are we able to begin to understand how people learn, and as such, tailor the learning for them to be able to maximize it? So enable and support returners. So there are people who have had career breaks, and then surprise, surprise, they come back and can't recognize things because technology has landed. So it is about how do we support people who are coming back to actually feel enabled to come back into healthcare and deliver the care that they've always known, but with technology as a means. If at all possible, I mean, some of us would happily sit in the classroom all year long if paid to do so, but that's not for everybody. So how do we begin to make learning fun? And I guess some of the points that has already been raised in terms of personalizing learning, using comprehensive learner profiles are things that could potentially support making learning exciting. So for us, we know that these technologies are not going to stop coming in. They're coming in faster than our ability to adapt to it. So it is very much about making people digitally ready, rather than saying that we're going to train everybody on every single gizmo or chatbot or whatever else that gets developed. It's really emphasizing and investing on making people digitally ready. Now, what do we mean when we talk about digital readiness? It's about the willingness and the ability. So much as individual attitudes to technology. So we did a discovery piece of work as part of developing a tool. And what was identified out of that discovery is we actually have 3 groups of people who are digitally negative and saying, go away, digital is not going to solve the world's problem. I don't want to know. And then there's the neutral group who are saying, actually, yes, digital is there, but still give me my pen and paper and let me get on with it. So they are not really fussed whether digital is here or not. And of course, there is a third group who are saying, we know that digital is going to make an impact. Teach me, help me make the most of it. So there are all of these groups. How do you bring the first 2 groups along so that they have the attitude and the willingness to engage with digital? as much as it is about everybody and the individual, it's also about the organizational leaders. So how do we get leaders, which I have mentioned, boards for that matter, to be able to foster a culture that supports individuals to get that engagement going and be enthusiastic about using digital. Now, the digital ability is about the skills. It is really crucial. Everybody needs to have the right skills. And for us, I mean, when we start talking about digital skills, everybody says the millennials, the young people, they've got the digital skills. And I'm now beginning to say, no, they haven't. So they might be social media savvy, they might be able to type at the speed of light, but actually when we talk about digital literacy or digital ability, HE defines that as the capabilities that fits one for living, learning, working, participating and thriving in a digital society. Now from that definition, I do not think our young people are digitally literate at all. So these are some of the considerations that we need to think about. So how do we get everybody to have those digital capabilities? But also recognizing that we as a workforce will not have all the capabilities, and sometimes we will need to depend on specialists. So informaticians, data scientists, we do need sometimes skills from even industry to be able to help us deliver this digital agenda. So in Health Education England, we've got a program called Building a Digital Ready Workforce. Now, this program actually started before the Topol review, but what the Topol review has done is reinforce the fact that we need a digital ready workforce. If we have any chance of implementing the digital, that's what we need. So looking on this slide, for us to be able to build a digital ready workforce, we need places. So we need organizations, community services, acute hospitals. We need places. We need people. As you can see, people are sitting around there. Is there a psychologist? Can't see one. That's not very good. But you definitely will be sitting around that table as people. Now, this program looks at a number of work streams. So you see the leadership work stream, and the leadership work stream is really looking at working with boards. So we've developed a program called Digital in a Day, and it's bringing boards together, and not just boards as in acute trust or community trust, or it's boards across a number of footprints. So it could be STPs, it could be ICSs, it's just boards and what the formation of those boards are. Because let's face it, more and more there is an integration of health and social care and different models of care. So we are paying attention to that. So that leadership program is currently being piloted out there. Now, the professionalism piece is really looking at how do we get people who belong to some form of a group. So informaticians for that matter. We do know that there are a number of them out there. They are in different roles within the NHS, but we don't know the numbers or what they call themselves. So we are trying to bring those groups together to form the family, because let's face it, we all want to belong to a family, which is why you've got this network of psychological therapy and practitioners. So it's about getting those numbers, and it's about them forming a professional family, but also understanding the competencies that they need to be able to have a career in those areas. How many people know about the Digital Academy? The NHS Digital Academy. So again, it is really supporting clinical informaticians right at the top to develop their skills. So again, that's another area that we are looking at within the professionalism. Being the greedy person that I am, I always take the big chunk. So I lead on the digital literacy work stream. And what are we doing with that? Really, it's about how do we develop digital capabilities for the health and care workforce. So whilst I started off with 1.4 million being the workforce challenge, actually the challenge that I am dealing with the digital literacy is 3.1 million, because we've got an additional 1.7 in social care. What are some of the things that we are doing within digital literacy? So at the moment, we are looking at developing a self-assessment diagnostic tool that allows an individual to assess their own digital literacy skills, identify gaps, and then be signposted to learning that's relevant to them. More and more, we need to recognize the importance of the so what. If we did do lots and lots of things but not address the so what, it really is not going to make any change. So it's being able to signpost people to what's relevant for them to learn, to fill in those gaps. Now, the third area that we're really keen on investing in is digital championship. So whilst there are people who are motivated or have the capacity or the capability to use digital tools or be signposted to learning, there are others that may initially probably need some hand-holding. And championships have been identified as a means of really supporting local ownership of tools, of ideas, of strategies, but also further skills development. So that's an area that we're really looking into. And the way that we're doing this is we've commissioned some championships in certain areas, but we are looking to evaluate a number of models to be able to support the system in understanding what works for who and where, and how much investment is required for that to happen. So these are the high-level implementation plans that we've got for the 1920, and I have already spoken about those within building a digital-ready workforce. So all of these pieces of work are ongoing, and at some point will certainly be coming to your door if it hasn't already. Some of you may be aware of some of the work we are doing and might be pilot sites, be part of pilot sites. I think for me, it's crucial that as we think about the workforce in its entirety and with digital coming in, HE has the style, which I love very much, because really what it is about is, we've spoken about supply. How do we enthuse people to come and work for the NHS, right from primary schools to secondary? So it's thinking, do we need to actually start bringing different people in? And Geeta mentioned earlier on that a new role within psychology is already here. So we need to think about this. It's about upscaling the workforce that we currently have. So we have a workforce that are really skilled and experienced, and how do we begin to use those experience and skills alongside introducing technology to support the future workforce that are coming in? So it's new ways of working. Can you work from home twice a week? Can you conduct that meeting online instead of having to drive 2 hours to go into a meeting? So it's about thinking about all of those when it comes to workforce, and leadership is key to all of that. For you specifically, how many people know about this piece of work? Okay, so this is one that I am really excited about. So as you would have it, I am somebody that really loves to join the dots. So rather than going off and doing things, I always want to find out who is doing what so that I don't have to do it. So as part of the self-assessment and diagnostic tool that we are working on, I got connected to Helen. And Helen said, oh, Henrietta, this is one piece of work that we are doing. The best thing, as anybody can see up here, is it's actually got the British Psychological Society invested in it. So this is a piece of work that I am excited about. What is this? So it is about, the framework is really to detail the knowledge and skills applied psychologists and psychological therapists require for working safely and effectively in a digitally enabled NHS and beyond. And then the second aim of this would be to include using technologies to communicate with clients remotely, offering online therapy or blended interventions, supporting clients in their use of health apps, and managing complex digital mental health records. So this piece of work, whilst we've got the generic capabilities tool, which has been developed by Health Education England, we do recognize that profession-specific competencies are required, because what we know from our evidence is if things are not contextual, it's really difficult for people to see how it applies to them. So I was really, really excited about this work. Unfortunately, I was going to show you the link to it, but the link is not working. Technology. But what I can say, though, is keep an eye out for it, because it will have implications for you as a profession, in terms of the specific digital competencies that you need to be able to deliver safe and effective care. So these are, there are a couple of names up there. If you want to make contact and have any conversations about it, there is a potential survey or something to come out soon, and I will keep an eye on it and send it to Claire to distribute alongside. So the group that are really looking at this piece of work is listed up there, and as you can see, it's quite a number of universities all across the country. So hopefully this is something that you will be getting more and more information about as it progresses. But I'm really excited excited because I think it links in really well with the central work that we're doing at HE, but also thinking specifically about the profession. And we're doing similar pieces of work with other professions as well, for example, the AHPs. So, in a nutshell, digital is here, but there are more and more emerging technologies which would have implications for us as a workforce. And I think that being digitally ready, which is having the willingness and the ability to use these, would be what maximizes our potential to really effect the best care or deliver the best care for our patients safely. Thank you.